Good afternoon, everyone. My name is Chris Power. I'm the President and CEO of Capital Health, and I'll give a short statement, and then we'll be open for questions. I have with me today Dr. Ward Patrick, who is our Chief of Critical Care at Capital Health, and Barbara Hall, our Vice President of Person-Centered Health, who are prepared to speak to any other questions that you may have. So we are now hours away from a legal strike of our members of NSGEU Local 97. And preparations for this strike, combined with yesterday's illegal strike, are having significant effects on our patients, and it is affecting health care across this province. Despite our continual efforts to explain to NSGEU why we require the numbers of registered nurses we do, service by service, for emergency staffing in the event of a strike, the union's best offer still comes far short. We have not agreed to emergency staffing levels that they have offered. The number of registered nurses the union is willing to provide would require us to close 14 of our 26 neurosurgery beds at the QE2. Almost all of these beds are full today, and we have little ability to move patients out due to their level of illness and the capacity of our other districts. We are the only hospital in the province who has a neurosurgery unit. These would be people with brain tumors, people who have had brain trauma from car accidents, etc. Our coronary care unit, where our heart patients reside, and several of our intermediate care units are 100% full. We will require 100% staffing to provide care. NSGEU had once offered 100% staffing to our veterans, but now is only offering 66%. These people live there and require our nurses to care for them. Despite our best efforts, we will have 100 patients in beds that we had been planning to close but are not able to do so now because of pressures in the rest of the province and because of the illness of the patients in our communities. As in yesterday's illegal strike, we will use every effort to provide the best care we can with the resources we have. But our patients and the provincial healthcare system will again be at risk. I'll now ask Dr. Patrick and Barb to join me here, and we'll be open to any questions that you may have of us.
Can we get those mics?
Joan Jessam said about an hour ago that there was an agreement from Capital District Health on the staffing required for emergency services. You just said there isn't one. She said it was delivered to her that Capital Health had agreed. So what do you have to say about that?
So we've never agreed to the staffing levels. They were the levels that the union had put forward to us. We had always required more staffing for many of our areas, and what we are continually back and forth with them today, and there are still changes being made as we speak, are the areas that are full of patients that we require registered nurses to care for them. And so for the union has agreed to provide certain levels. We as professionals and our physicians and other professional colleagues are saying that's not sufficient to care for the patients we have in our bed. Dr. Patrick may want to speak to some of that as well.
So just to let everyone know, we've actually had, I think, unprecedented help from the other districts, at least in my working relationship here in Nova Scotia. They have done a remarkable job of bringing the numbers down of people who require services. Remember, we provide direct care to the people in this district, which is about 40% of the population, but we also offer care to the other 60% of Nova Scotians who require us because they can't get what they need in the districts. The districts have held on to patients, have tried to offload us, and actually that's allowed us to come down by about 170 beds. So despite the best efforts of the province, we're still going to be about 90 beds above where we'd like to be going into a strike tomorrow.
Is there anybody's life in serious jeopardy because of this strike?
So we're going to end up in a situation where we're going to have more beds, more patients in those beds than we have staffing for at the present time. If you're asking me, is it possible that someone can be hurt? The answer to that would be yes. There is no way to know what's going to happen tomorrow until it happens. But there is no doubt these are not the staffing levels These are not the number of beds that we would want going into a labor disruption.
So was there an agreement on something reached today? Because when we spoke with Joan Jesson, she said she heard just half an hour ago that an agreement had been reached on the protocol. So was an agreement reached on a certain aspect of that protocol?
So the agreement that had been reached was on the process. The agreement has not been reached on the numbers, and we continue to go back and forth with the union in trying to get additional staff, additional registered nurses for the areas where we believe that our patients may be in jeopardy if we don't have that expertise to care for them.
So what's the difference between an agreement being reached on the process and on the protocol?
Can you repeat your question?
That an agreement has been reached on the process, but not
So
on
the process that's been outlined in the collective agreement since 2001 on emergency service levels, and you think about that, 2001 is very different than 2013, and how we care for patients now and the numbers of staff who are required to do that. But we had agreed that we would sit down and look unit by unit at the numbers of nurses who were required to care for that particular patient population. So that was agreement on the process that's outlined in the collective agreement. However, the numbers of staff are very, very different than they would have been even 2 years ago than they are now because of the kinds of patients that we're caring for and because of the situation we find ourselves in. So we've made every effort to reduce the numbers of beds as we always would in a strike. We simply cannot get there because of how sick our patients are. And patients are in hospital because they're ill. And they need care, they need nursing care, and they need the care of all of the health providers who are around them. So that's our issue today. We have more patients in beds than we had planned for, despite everybody's best attempts to get them out. Patients keep coming to our doors. People continue to get sick.
Just to make sure that I understand this, so your concern is that the agreement is on 2001 levels, which are now completely different?
That's the starting point, and we have been working with the union, and they have, they have conceded in a number of areas. We have 100% staffing in our ICU units, cancer units, so there are areas where they have agreed to that. Our problem now is that we have a number of areas where we do not have sufficient staffing to provide emergency care. This is not the same at all about essential care.
So just to clarify in my own mind, you do have an agreement with the union to provide full staffing in all emergency rooms, intensive care, and dialysis and cancer units.
That's right.
That's
and
not on the table at all.
That's not on the table. That's right.
Okay. So what are patients to think? I mean, listening to you today, the outlook is not good by any measure. If I had a loved one in here today, I'd be worried. What are people to think out there who are listening to this?
So I'll give my perspective, and then perhaps Ward and Barb, Dr. Patrick and Barb would like to step in. I would say that we will do what we do every day. We do the best we can with the resources that we have. Our sickest patients are always the patients we'll focus on. We triage, or we look by levels of illness for our patients every single day. And so that's what we'll continue to do. We have our management teams, we have other people who will be lending a hand to do some of the basic work, but for our skilled professionals that we need, we will be making sure that our sickest patients get the care that they require. I don't know if you want to add anything, Dr. Patrick.
So I'm not sure that this adds much, but just a reassurance. The people who are in the intensive care unit, we are fully staffed. We'll be able to look after them. The CCU will be about 70% staffed, so people who have heart disease and heart attacks, they won't be fully staffed, but we think for a short period of time, and I've got to stress this is a short period of time we're looking at, that we will be able to cope by using other people to try and help out. But this is not sustainable over any period of time.
So I know that Greg Boone, for example, down in the Cape Breton District Health Authority, mentioned that they were prepared to take patients from not their own returning, but our patients here, if need be. Is there any move to, in this short space of time, relocate Capital Health patients to outlying district health authorities?
Sure.
Well, for example, yesterday we moved 4 inpatient detox patients to other places within the province, so we've already started that kind of process. What we have to be really careful of is there are certain things that are done here that are not done anywhere else in the province. So the people that are the sickest that only can be cared for here, there really isn't another option. We have alerted the provinces around us that might have some capacity in a true emergency situation, but clearly that would be an absolutely last resort. What the other districts have been helping us out with is getting their patients that we look after home really quickly, and also freeing up some capacity in their own districts to look after maybe some secondary care. But the tertiary and quaternary, the high-level specialty care that can only be done here, it would be really hard to move those anyplace else.
And my last question is, are there any plans to bring in RNs from other health districts to fill the void here during a strike?
So no, we have not moved to that level. Currently, we'll be continuing to work with our union and hope that they will come through with the staff that we need to provide service on an emergency basis.
The NSGEU president said that this strike is not going to last much more than 30 hours. So can you deal with this for 30 hours?
Well, we'll have to. Right? We don't have a choice. We have patients in our bed who need our care. So if that's how long the strike lasts, then we will have to make sure that we're caring for the patients in our midst. As Dr. Patrick says, we can do anything for a short period of time and rally around, but it is not sustainable for any length of time.
She also said that she's prepared to go back to the bargaining table right away and the strike could be averted. Is there a point to going back?
Well, we are always happy to go back to the bargaining table and see if we can work through issues. I mean, the key issue on the table for us is nurse-patient ratios that we're not willing to compromise, although we did put forward in the last time we were at the table a process outside of collective bargaining that we would absolutely entertain to sit down and start to look at. So we're always prepared to go back and have conversations, and we'd welcome that opportunity.
So who blinks? Are you going to call her, or are you going to wait for her to call you?
The offer is always out there for us to come back to the table. The union walked away last time from the table, so we wait to see if they'd like to come back with us.
There was a change in August last year for overtime and calling in individuals if someone called in sick, correct?
There was no change. What memo went out to our managers to say to them, before you automatically replace for sick calls or think about overtime, look at your staffing, look at the patients who are on the unit, and see if you can manage with the staff that are there. At no time did we ever say you will not replace a first sick call or you will not call overtime. We do this every single day, every single shift. Look to see what our patients require, and we act accordingly.
But it was a policy change initiated for the purpose of trying to reduce the amount of staff. And basing on what you just said, it is, do you really need all the staff that you're going to have? So don't replace these people if you don't.
So no policy change. We've done that for years and years. It was just heightening people's awareness to the fact that we don't always automatically need to replace staff, no matter if they're registered nurses or whoever they are. So just a reminder to people to think about that before they automatically make a phone call. Make an assessment. It's what we do every single day. So be sure that we're making the assessment to see, do we truly need the staff who are coming here?
So are you overstaffing in the first place?
No, we're not overstaffing in the first place. We are looking at what the patient population needs, and that's the staff that we bring in every single day. We have a lot of sick calls. Things change. We're a very dynamic environment. We may have, on any given unit, more sick people on one day than we do on another day. So it changes for us every single shift. It can change within an hour of what our patient needs are.
Jane, and then
What's the situation today? I'm just wondering if everybody's back at work and how are the feelings after yesterday?
Yes, everybody is back to work. They came back last night, and people all came to work this morning. I think it's fair to say that our staff feel very conflicted. This is a difficult time for everybody, not just the nurses who are poised to strike tomorrow, but all staff. Tensions are high. However, I will say that, as always, we are proud of the professionalism that despite the feelings of conflict and the tensions that are in the workplace, staff show up and in a very professional manner and work to look after our patients.
And have you canceled any surgeries today as a result of the situation yesterday or the anticipation of the strike for tomorrow?
Yeah, so we've been in a 14-day countdown. We have a plan every single day. Today we're only doing outpatient surgeries or for emergency, life or limb, for people who may be inpatients in our beds. So we've canceled 24 patients who would have been scheduled for surgery who would have to stay in the hospital afterwards. Their surgery has been postponed, and we'll be rescheduling that. But our outpatient surgeries are going ahead. All of our clinics are running full steam ahead today. Tomorrow we will be emergencies only for all of our services, with the exception of some outpatient ambulatory clinics that, if they are not dependent on nurses, they will be able to go ahead.
Thank you.
Thanks very much.
Before you go, I spoke to a young nurse who testified at the public accounts last night, and she said that she works with palliative care and that there are circumstances when there's a nurse that perhaps is sick, there are 8 to 10 patients, what they call, I guess, active dying, and it comes down to a choice of which patient a nurse is going to end up sitting with because they're short-staffed. So some patients may be left to die on their own. What do you respond to that woman?
So that's always a very unfortunate situation for sure. Not that we'd ever want that to happen, but those things happen. Despite staffing being planned, to have sufficient staffing for that evening, if people call in sick, if there are circumstances where we don't always have the staff and can't get staff, what we do is what we do in situations like this. We do the best with the staff that we have available. People have to make difficult choices. It's not how we ever want care to be provided, but from time to time, unfortunately, that's what happens despite everybody's best efforts. And it's very difficult for those nurses in that position. It's difficult for our patients and their families. But that's never the way that we want care to be provided.
But doesn't that speak to staff shortage?
Oh, it speaks to, despite however many staff you had on scheduled to be on that night, if people called in sick and there weren't other people to be there. Every single day, we're recruiting nurses to come to Capital Health. We're recruiting all of health professionals. We're a big organization. We have 12,000 staff. There will be times, and there are times. We know right now there are places where we have shortages of staff. It's not that we're holding back for financial reasons. We are trying as the best we can to get the appropriate staff for all of our areas. That's our job. That's what we do.
Ms. Bauer, are you concerned that this could drag on for more than 30 hours as predicted?
We certainly hope that won't be the case. We're anticipating that the legislation will be passed on Friday, so what we are planning for is, about a 36-hour window, and are hopeful that it will end then. As Dr. Patrick said, this is not a sustainable plan for us to continue to go for any length of time.
But given the short duration that is expected, I have to assume that the level of uncertainty about safety to patients has probably dropped considerably. Is that fair?
Every day that we don't have our nurses here is a concern for us. Every hour that we don't have our nurses here. If we didn't need them, they wouldn't be here. So this is a huge concern for us and for the safety of our patients. We will do the best we can to provide a safe environment with the resources we have, no matter if it's 1 hour, 36, or 6 weeks. That's the situation we find ourselves in. Thank you.